Thank you, Jane. Yes, and hello and welcome everyone to this workshop about coding of medication errors and other product use issues. I'm Caroline Wilson and work as a medical officer at the MSSO. I will be your instructor today. Jane mentioned this already, and I'm supported by her. She was speaking to you before. Together we will take you through this workshop, which will last for about 90 minutes. We would like to make this workshop interactive, so please submit your questions or send us your comments through the question panel, the chat panel. But one remark, please do not raise specific coding questions as we can't help you with individual verbatim terms. But we will guide you in terms of coding principles, of course. We are quite a large group today in terms of registrations, and it may be that we cannot address all your questions during the workshop due to time constraints, but we will then address them individually via email with you. You may have seen that we are offering 2 of these workshops in a row, today's workshop and another one on Thursday this week. We do so to allow more participants to take part in the workshop as the number of attendees is limited to 150. Please note that each workshop pair will always have the same content, so don't register for both of them. But the topics and exercises of the workshops will change over time. After each General Principles for Medication Error Coding webinar, there will be a workshop pair with new examples, new exercises. But depending on the number of participants, we may only offer 1 workshop in the future. But currently the interest is still high. Before starting, I have to say that I'm a bit handicapped today because of an acute COVID-19 infection with cold symptoms like cough and quite a raspy voice. So please excuse me if I cough in between and also drink some water. I didn't want to cancel this course on short notice, and I also hope that I won't be additionally affected by brain fog. So I will do my best, and now let us start with the presentation. You all know that ICH adopted the development of MedDRA in the mid-90s and became the owner of the terminology. ICH then, on contract, appointed the MSSO to take care of the maintenance and further development of the terminology based on user feedback. Also to provide and organize corresponding training, like the one that we have today, and to administer the MedDRA licensees. All these MSSO activities are overseen by the ICH MedDRA Management Committee. ICH not only owns MedDRA, but also owns this training material. It is protected worldwide. You may use the slides, with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point here refers to warranty and liability issues you should be aware of. And the third one is not relevant for today because we will not be using any third-party slides. This workshop nicely complements the webinar provided end of April about the general principles that we have to consider when coding medication errors and other product use errors and issues. I hope that you have attended this webinar because our workshop today builds on this webinar. Now let me provide you with an overview on what we will cover today. I will firstly go through the most important general principles for coding of medication errors that we discussed in more detail in the previous webinar. So it will just be a brief overview. We will then apply these principles in exercises using the verbatims and narratives that you have received beforehand last week. And we will conclude with a question and answer session as mentioned before, but we will address your questions and comments throughout the workshop as well. So please use the questions panel to ask questions and for your comments. As I mentioned at the beginning, we want to make this session as interactive as possible. And as already stated, we will not address specific verbatims that you may propose via the questions panel. But you have the option to propose new examples for consideration via survey at the end of the session, or via an email to the MSSO help desk. We may consider them for future workshops, but they really have to be of general interest to the wider audience. Now, this slide explains about the polling. Jane mentioned this already. If you would like to join the quizzes and actively participate in coding of our exercises today, please enter the indicated web address, paulf.com, into the URL bar at the top of your internet browser in your computer, tablet, or cell phone. It will then take you to a log-on screen that you can see here, and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my name as the username. That is Carol N. Wills 584 with no spaces, and then click join. Or you may also scan the QR code that you can see on the right-hand side with your smartphone, and it will bring you directly to the poll. That's the easiest way to access the poll. And as soon as I activate the first question, you'll be able to see it and respond. So I just leave it on the screen for a moment to allow you to enter the required information or to scan this QR code, but you don't have to get under time pressure because you will be able to see these credentials on each slide that relates to the quizzes. And Jane has put these credentials in the chat as well. And if you lose connection, let us know as well. I can show the QR code during the session again. Now, let's test it, whether it works. So where are you joining from today? Where are you located? I see Germany, Guten Morgen, Italy, Buongiorno, Portugal, Bon dia, Spain, Colombia, Buenos días, or maybe es en la noche. I see North Africa, Australia, so Korea, China, India. So we have a global audience, obviously. So thank you for joining and welcome everyone. It seems that the poll is working. Now let us start with our short recap. As mentioned in part 1 of the medication error coding webinar, the topic medication errors is a critical and important problem in healthcare. Many regulators have a close eye on such occurrences, the contributing factors, and related adverse events in patients. They support the recording, coding, reporting, and evaluation of these errors in order to gain new insights into the extent and also the causes of medication errors. And all this with the objective to develop improved strategies for their prevention in order to better protect patient safety. Here just a short reminder regarding the basic rules to be followed for coding with MedDRA that are of course also applicable when coding medication errors and other product use issues. The quality of the reported information and the extraction of the relevant information during data entry are a basic requirement for good and meaningful coding. If the information received is vague or ambiguous, of poor quality, then ask for clarification. Coding is done at the LLT level, and the LLT that most accurately, most specifically reflects the reported incidents and events should always be selected. Nothing should be interpreted, added, and no relevant information should be omitted. This is the basic rule, code as reported. And of course, only current LLTs should be used for ongoing coding. For coding product use errors and problems, the following tips may be helpful in addition. First and foremost, you should be familiar with the MedDRA concept descriptions, and I will show some of them today, and the PTC guidances, points to consider guidances, so that you know where to find more detailed information, more guidance. You should also have a good knowledge of the MedDRA structure and hierarchy, particularly in shock injury, poisoning, and procedural complications. And once you have found a potentially appropriate LLT and PT for the reported incident, check if the placement of the selected LLT and its corresponding PT accurately reflects the reported event. Always check the hierarchy. It is best to search the MedDRA hierarchy top-down when coding medication errors and other product use concepts, unless you are already very experienced in coding such incidents. And finally, if you can't find a specific term for either medicines, vaccines, or medical devices, look out for a product term that would be suitable for your coding task. The following chart can be used to classify medication errors and other product use issues. It visualizes the related decision-making process, and we will be using this decision chart throughout the session today. Here are the core questions that you will have to ask yourself. 3 questions. Did the incident occur intentionally or unintentionally, accidentally? Who caused it? Who triggered it? And was it in the context of therapeutic use or for therapeutic purposes, yes or no? Let us assume that the unapproved product use took place intentionally. If it is decided by healthcare professionals and for therapeutic purposes, we classify these incidents as off-label use. If this originates from the patient or consumer and happens in the therapeutic setting, we classify this as intentional product misuse. And if the deviation does not occur in the context of therapeutic use of the product, the deviation is classified as drug abuse or drug addiction, dependence. If the unapproved product use is unintentional, accidental, this can also be caused by both the healthcare professional or patient consumer. This always occurs in the context of therapeutic use of the relevant product and is classified as a medication or product use error. But often, case information does not allow for any of these classifications. So what can be done when getting similar, more vague reports for coding purposes? For these scenarios, the flowchart must be expanded with 2 neutral terms. And you see the question marks here now. If it cannot be clarified whether an intentional deviation from the label by the patient or consumer happens for therapeutic reasons or not, an appropriate LLT under PT intentional product use issue should be assigned. And if it cannot be clarified whether such unapproved use occurred by mistake or intentionally, an appropriate LLT under PT product use issue should be assigned. So these are the more vague PTs that we can use if we don't get sufficient information for clear classification of these incidents. Please remember the definition of the term medication error as well when working on our exercises. A medication error is any preventable event that may result in the improper use of medication or harm to the patient, while the medication is under the control of those involved in the medication process, meaning physicians, pharmacists, nurses, patients, consumers, or their families. The second aspect here that is highlighted in green is important to remember. These errors occur during product use in the medication process, when the product is under the control of the healthcare provider, patient, or consumer. The term does not refer to errors that occur during manufacturing or are caused by wholesalers or other external parties or factors which are outside of the control of the healthcare provider, patient, or consumer. Medication and other product use errors may be related to professional practice, the products themselves, and healthcare processes in systems, including prescribing, communication of orders, product labeling, product packaging and nomenclature, preparation of products and their dispensing, distribution, and administration, as well as related education and product monitoring. Here one last hint. Before searching for suitable terms for such coding scenarios, you should always first assess the reported information, the verbatim. First of all, check the 3 criteria for the classification that we already saw in the decision chart. Did the incident occur intentionally or unintentionally? Who has caused it? Was there a therapeutic purpose? Then check at which stage the error occurred, because we should always capture the stage where an issue or error occurred, and whether it led to subsequent errors and even harm in the patient. If contributing factors are reported, they need to be captured in addition. This is what we call the root cause. Or was the report referring to circumstances that only could lead to a medication error, but no error occurred yet? Or was an error made but subsequently intercepted before reaching the patient? Because the type of report, the type of information that you get, will influence the way you search for appropriate terms. The exact understanding of the reported information will help you find the most suitable LLTs, the closest matches. It will make your search more efficient and more targeted. With this, let's apply these principles and work on our exercises. Please use the MedDRA browser and try to find the best LLT or LLTs to code the verbatims which we have sent to you before this workshop, and do your searches either top-down or bottom-up to find the most specific LLT or LLTs. In some instances, split coding will be necessary. We will use Poll Everywhere for the submission of your proposals, and we will review and discuss the correct assignment for each verbatim. Here the information how to access the browser, the username, and the password. Please note that this is a temporary demo password only that will expire in a few days from now, but you can of course also use your company-specific credentials for this accessing the MedDRA, MSSO MedDRA browser, or your company-specific browser as well. And Jane has also put this information in the chat. Now let's start. Here's today's first exercise. A physician mistakenly prescribed a drug for a patient which was contraindicated in patients with that particular genotype. Now let's look at the verbatim first. Was it accidental or intentional? Who has caused the incident? Was it for therapeutic purposes? At which stage in medication practice did the incident occur? Do we have to split code in this instance? Was there a root cause that needs to be captured? And was the medication error intercepted, or was the report referring to a potential occurrence of a medication error only? So here, the first 5 questions can be answered and have to be taken into account when looking for suitable LLTs. Here's the first poll. So how would you approach this verbatim? Physician mistakenly prescribed a drug for a patient which was contraindicated in patients with that particular genotype. Would you assign medical treatment contraindicated, contraindicated drug prescribed, drug prescribing error, contraindicated drug administered, labeled drug disease interaction medication error, or labeled drug genetic interaction medication error? What would you do with this verbatim? I see many of you are voting already. So more than one LLT may have to be assigned in this instance. Now let's have a look at the trends here. So most of you are voting for contraindicated drug prescribed, others for drug prescribing errors, labeled drug disease interaction medication error, and labeled drug genetic interaction medication error. So these are the options that you are voting for. Let me close this and first look into our decision chart. So what do we have here? Physician mistakenly prescribed a drug for a patient which was contraindicated in patients with this particular genotype. So it was accidental, it was caused by the physician, it was in the context of therapeutic use of this drug, so it has to be classified as a medication error. Now let us check in the browser for our suggested LLTs. So in order to access the browser, here's a shortcut to the web-based browser on the MSSO on the MedDRA homepage. Here we are. I don't want to have Chinese, I want English, and log in. Here we are. Newest MedDRA version, English, SOC view, here we are. So the first LLT that was suggested was medical treatment contraindicated. Oops. Brain fog. Here we are. Medical treatment contraindicated. If I click on the plus sign, I can see the hierarchy: contraindication to medical treatment, social issues, lifestyle issues. It's grouped in social circumstances. That is why it is always important to check the hierarchy of terms. So if I do a right mouse click and go to the browser, I can also see this term in the hierarchy. You see it's in social circumstances with other PTs. Here we are, like blood donor, blood product refusal, etc., etc. So social circumstances would not be suitable in this instance. This would not be a correct assignment. We should always capture the stage when error occurred. So in this instance, it was the prescribing stage. So it was a contraindicated and it was prescribed. Let me search. Contraindicated drug prescribed was the other options that we had. Here we are. Go to the browser again, and now we are in the injury, poisoning, and procedural complications SOC. Under HLGT medication errors and other product use errors and issues, you see that the HLTs group the PTs according to the stage where the error or issue occurred. Here we have an issue at the prescribing stage. It was an error. And the most specific term that we can find is contraindicated drug prescribed. We know it was contraindicated. We know it was prescribed. The other option would be product prescribing error, PT. Let's look if we have a similar term there for an error that was done during prescribing where a contraindicated drug was prescribed. No, just wrong drug prescribed is available, drug prescribing error, drug dose, administration, dosage. No, nothing. So this seems to be the best approximation to what has been reported because it contains, it reflects the stage where the error occurred, and it really describes a specific type of error. The other option was contraindicate administered. Of course, we also have contraindicated drug administered. Right mouse click, go to browser. You will see that it's grouped in a separate HLT for the administration errors and issues. It's a separate PT, contraindicated drug administered. But here in this instance, we are not told that this error actually reached the patient. It may have been intercepted. We don't know. So again, this would be inappropriate. This code assignment would be adding information. This was not reported. Then we had two options. First of all, the labeled drug disease interaction medication error. And here we are coming to the concept descriptions that I mentioned already when talking about hits and tips for coding medication errors. You find the concept description here on the top in the browser. Here they are. And if I look for medication monitoring error. You'll see for the purposes of term selection and analysis of MedDRA coded data, a medication monitoring error is an error that occurs in the process of monitoring the effect of the medication through clinical assessment and/or lab data. It can also refer to monitoring errors in following instructions or information pertinent to the safe use of the medication. So this is a general concept description for monitoring errors. Now we have the labeled. Here we have the labeled drug-disease interaction medication errors. This was one of the options in our poll. This medication error refers to the situation when a patient is prescribed, dispensed, or administered a drug that is documented in the drug label as having the potential to exacerbate or worsen the patient's pre-existing diseases. Example, a patient has a medical history of having bleeding gastric ulcers, and however, the patient was inadvertently prescribed and dispensed several doses of aspirin. So this is not applicable to our verbatim. Here, let me show you where to find the monitoring errors. Here they are, product monitoring errors and issues, separate HLT again. And here we have the labeled drug-disease interaction medication error terms. As you could see in the MedDRA concept description, these would not be appropriate. They do not reflect what has been reported in our case, but we have a very specific new term here that is labeled drug-genetic interaction issue. And if I do a right mouse click again on this LLT and say open history, you will see this is a brand new PT and LLT. In this instance, it was just added in the most recent version of MedDRA 25.0. So this would be the best code assignment in order to capture the monitoring error. Oops, wrong tab. Let me switch back to my presentation. So an example for a monitoring and resulting prescribing error can be found in the PTC companion document. So points to consider companion document, one of the ICH guidance document that we offer to MedDRA users. So here a provider prescribed 2 drugs with known drug interaction because he was unaware of the interaction potential. And you see labeled drug-drug interaction medication error would be the LLT in order to capture the monitoring error. And you would also have to capture the stage where the error occurred by using drug prescribing error. You may now argue that in our example, the LLT contraindicated drug prescribed does not explicitly capture the fact that this prescribing issue was made in error. But it is hard to believe, first of all, that non-observance of a contraindication by a physician is done on purpose. And also, the PTC companion document provides useful guidance in this respect. As in addition, see the second example here. Patient inquired about possible overdose symptoms because she accidentally took an extra dose. So this would be coded to extra dose administered. And we are told, although the LLT does not capture that it was accidental, it falls under HLT product administration errors and issues, and this is obviously considered sufficient for assignment of this code. So it's not necessary that the contraindicated drug prescribed really refers to or contains the information that this prescribing issue was made in error. And also, we have to consider that in our example, we already captured the error with the LLT labeled drug genetic interaction medication error. So here is the final proposal. We would code to LLT labeled drug genetic interaction medication error under labeled drug genetic interaction medication error, same PT, and in order to capture the stage where this error occurred, contraindicated drug prescribed, under PT, contraindicated product prescribed. And most of you have voted for this LLT, so well done. Any questions, Jane?
No questions so far, Carol-Ann.
Okay, so just raise questions, send us your comments to make sure that this is really fully understood and that the rationale for assigning these codes, these LLTs, is fully understood. So next exercise. A patient stated that he didn't read the instructions and left his insulin on the kitchen counter at room temperature instead of storing it in the refrigerator. Based on our verbatim, we can answer again the first 5 questions. Look at the verbatim before making your decision. Look at whether it was accidental or intentional, who has caused it, was it in the context of therapeutic use, at which stage in the medication practice did the incident occur, and do we have to split code, yes or no? Next poll for you. Here you see the verbatim again. Now, what LLTs would you assign? Product storage error temperature too high, incorrect storage of drug, product temperature excursion issue, suspected product quality issue, poor quality drug administered, or expired drug administered. What would you do? The patient didn't read the instructions and left his insulin on the kitchen counter at room temperature instead of storing it in the refrigerator. You're still voting. Now let us check the trends again. Product storage error temperature too high or incorrect storage of drug are the favorites, but also product temperature excursion issue and suspected product quality issue or product quality issue. Let me close the poll again. And look at our decision chart. So here we are. Was this intentional or accidental? Well, it was accidental. The patient didn't read the instructions and left his insulin on the kitchen counter. It was caused by the patient and in the context of therapeutic use. So again, a medication error. We'll switch to the browser again. Product storage error. Storage temperature and high. Product storage error temperature too high was the first option. It's under product storage error. So let us explore, go to the browser again, the content of this PT. The other option was incorrect storage of drug that we saw in the poll. Of course, the most specific LLT is product storage error temperature too high. Here we are. It's grouped under product storage errors and issues in the product use system. This is the HLT, and we would capture the stage where this error occurred. Now let me show you, you may now argue, well, we are not told that this was actually an error. Yeah, it's not contained in the verbatim. Is this an interpretation? Is this addition of information that was not provided? Again, let's look into the concept description. Product storage. Here we are. HLT, product distribution and storage issues and sub-product issues, is intended to cover issues with the storage of products by manufacturers, distributors, wholesalers, etc. In contrast, product storage issues by end users, such as healthcare professionals, patients, and consumers, are considered to be medication errors and are presented by the appropriate medication error terms in HLT product storage errors and issues in the product use system. So all storage deviations from storage instructions by end users are considered medication errors. So we don't have to have the information that this was actually an error in order to code to this PT product storage error. And we would, of course, use the most specific LLT that we can find under this PT, and this LLT would be product storage error temperature too high. Now, can we assume that the insulin has a poor quality after the storage error? Some of you have voted for this option. Well, we can't. We don't know how long it was left on the kitchen counter. Maybe it was just a short time period, not putting at risk the quality of the product. So that is why LLT suspected product quality issue and LLT product quality issue are not suitable. They are grouped in SOC product issues and are uniaxial. So let me show you. Here we are. Go to browser. You see they are grouped in product issues. They are uniaxial. And here we have the suspected product quality issue and also product quality issue. And you see that product lot specific issue, product quality complaint, topical product difficult to remove from application site. So these are more specific LLTs under these PTs, but these would not be suitable because we don't know. It would be an interpretation, it would be addition of information to this reported incident. And the same holds true for the LLT expired drug administered. And let me show you why. Because there are sometimes there's some confusion about the meaning of expired. So here's a definition taken from an FDA Q&A page. Drug expiration dates reflect the time period during which the product is known to remain stable, which means it retains its strength, quality, and purity when it is stored according to its labeled storage conditions. The expiration date is the date that is printed on the product packaging and/or container. And in our case, the drug was not stored according to the label. It was stored at higher temperatures than indicated. That is why any LLT referring to an expiration date is not applicable. Here again, the concept description of product storage as a reminder. Only use related PTs in SOC product issues when the storage issue occurred when the product was under the control of manufacturers, distributors, wholesalers, etc. Product storage issues by the end users, meaning healthcare professionals, patients, consumers, are always considered medication errors, and similar incidents should be coded using the appropriate terms in SOC injury. And here we are, the final suggestion. We would code to LLT product storage error temperature too high under PT product storage error. Did we receive any questions or comments for this verbatim, Jane?
We have had a few comments on this one. So firstly, one of our attendees is asking, can you explain what you mean by product temperature excursion issue?
Well, it's something that during the manufacturing process, or when the drug or product was on the way to the pharmacy, for instance, the temperature conditions were not met as indicated in the label. So if they have to be stored at low temperature, these conditions were not met. So it's an excursion. It's something that deviates from the defined temperature indication in the label. I hope I made myself clear here.
Then we've got a couple of other related questions asking, why are we not selecting a product storage error? Why are we considering product storage error temperature too high? And what about another related is, why do you choose that? Could you assume that it was climatic conditions when it happened, that it was the climate? How can we choose temperature too high where it could have got hotter?
Yeah. So I think this is not an interpretation. This is just a practical consideration. If this drug, the insulin, needs to be stored in the fridge, it is stored at 4 or 5 degrees. I doubt that in any kitchen there is a temperature of 4 or 5 degrees. So it was stored on the kitchen counter, so at room temperature. And this was definitely too high as compared to the instructions in the label.
Yes.
So that's why this would be the most specific term that we could select. Of course, it just only contains the information product and not drug, but this is the specific term that we can use for coding the incident.
So we've had comments that some of our attendees think it's an assumption that it's too high, but I agree with you, Caroline. If it says it should be in the fridge, then the room temperature is too high. That I don't think that's an assumption either, but I think we've got a slight difference of opinion on that one. How do you differentiate between LLT's product storage error temperature too high or too low if the storage condition was not provided?
Well, if the storage conditions are not provided, then of course you have a problem. Then you would maybe just go to a vague term like drug, as I have shown you earlier. Here we are again, like injury, poisoning, procedural complications, medication errors. Here we have the storage errors, product storage error. And here you would then select maybe not drug stored in wrong location. You could say, well, it was not in the fridge, it was on the kitchen counter, or incorrect storage of drug. Just a very vague term. You would capture the information that it was a drug, and you would at least capture the stage where this error occurred. If you don't have references in order to really clearly say whether it was too high or too low, then you would take this one. Okay. Because there's no more general term that would include the information temperature under this PT.
So that's all we have around that for now, Caroline. You carry on and we'll come back later with others.
Okay.
Thank you.
Next one. Here it is reported that a patient skipped a few doses of her immunosuppressant after exposure to a COVID-19 positive relative. She experienced a flare of her RA. So this is our verbatim. Again, we will have to ask the usual questions. And here we can really answer the first 6 in this instance, because we also have a root cause for this deviation. Skipped a few doses of a immunosuppressant after exposure to a COVID-19 positive relative. She experienced a flare of her RA. So we have a chain of events. We have a deviation of the treatment regimen. We have a root cause, and we have a subsequent adverse event in the patient. How would you approach this verbatim now? Would you go to COVID-19, exposure to COVID-19, fear of disease, intentional dose omission, intentional misuse in dosing frequency, drug dose administration interval too long, RA, or rheumatoid arthritis flare-up? Which LLTs would you select? Excuse me. So we have 100 votes already. Let me check the trend. Most of you are going for exposure to COVID-19, intentional dose omission, and rheumatoid arthritis flare-up. But others also vote for intentional misuse in dosing frequency. So it will be difficult to differentiate these two. Let me close the poll. Here we are. And again, look into our decision chart. So did the patient skip the doses accidentally or intentional? Well, she skipped them because she was exposed to a COVID-19 positive relative. It was a conscious decision on her end, most probably because she was afraid that her immune system would not be able to protect her from a COVID infection and a severe cause of the disease. So it was intentional. It was an intentional deviation from the prescribed dosing regimen by the patient, and it happened in the context of therapeutic use of the immunosuppressant, meaning that the incident represents an intentional product misuse. Let us again check in the browser. So COVID-19, of course, is available. Let me do an advanced search because otherwise I will exact match. I will get a long list of COVID-19 terms. Here we are. Of course, we have a direct match here, and this LRT is grouped under the same PT COVID-19. But the patient herself, she didn't suffer a COVID-19 infection. She just was exposed to a COVID positive relative. So that's why the exposure contains an exposure term is more appropriate. Here we have the exposure to COVID-19, so under PT exposure to SARS-CoV-2. So this would be the appropriate term selection for the root cause for the deviation of the treatment regimen by the patient. The other term, let me go back to the basic search here, fear of disease. Is of course available in MedDRA. Direct match, here it is. And if I go to the browser again, you see that it's grouped in psychiatric disorders. And based on Dorland's definition, the fear is a unpleasant emotional state that includes psychological and also physiological responses to a real external threat or danger. And these responses include agitation, alertness, tension, alarm reactions. But our verbatim provides no hint in this direction. So remember the basic rule, code as reported. We would add information when coding to fear of disease in this instance. Now, the next option was intentional dose omission. Here we are, search. Go to browser in order to check the hierarchy again. It's under intentional product use issues. It's not grouped under the product misuses, so it's a more vague term, intentional dose omission. It would not reflect what was actually reported. It would not reflect the misuse. And also, our verbatim says that our patient omitted several doses. So again, let's look into the concept description under dose omission. Here we are. The failure to administer an ordered dose to a patient before the next scheduled dose, if any. This excludes patients who refuse to take a medication, a clinical decision, or other reasons not to administer. So the dose omission really refers to only one dose. And in our case, in our example, it is reported that the patient skipped a few doses, and we don't know whether this was in a row or whether she regularly skipped every second dose. We even don't know how many doses she has finally missed. So, and therefore, if we look into the intentional product misuses and do a top-down search here, we have the intentional device misuse, drug delivery system, product misuse. Let's look at what we have here. By dose change, she didn't change the dose, but she changed the dosing frequency. So this would be the best approximation, the best LRT that we can find for coding our reported incident. Intentional misuse in dosing frequency. Drug dose administration interval too long. It would be an administration error and issue. Inappropriate schedule of product administration would be the PT, drug dose administration interval too long. So this would mean that it's really a more regular skipping of doses. We don't know that. We don't know how many doses she has skipped, whether it was a regular omission of doses whatsoever. So that's why this one would not be appropriate. And also, with this LLT, drug dose administration interval too long, we would not cover the fact that this was an intentional misuse. So the best approximation to our verbatim would be intentional misuse in dosing frequency. Then the patient experienced a flare and exacerbation of her RA. Let me do an advanced search again. Exact match, because if I enter RA, I would get a long list for this string. And you see that RA is considered an unambiguous abbreviation. It's current and it's grouped under rheumatoid arthritis. But we know, go to the browser, let us check the content of this PT in order to look for a term that would capture the flare of the RA or an aggravation. And you see that rheumatoid arthritis flare-up is available, and this perfectly captures what has been reported in our verbatim. So here again, we were in the browser, just a detailed description of the concept dose omission is available in the companion document, just to let you know. And also it is described which scenarios have to be taken into consideration when coding such incidents. So dose omissions may, of course, happen accidentally when the patient misunderstood instruction, etc. They may occur intentionally, as in our case, misuse. Patient skips a dose of an anti-diabetic because of low blood sugar, medicine held on day prior to surgery, or the dose omission may also be unspecified, where the cause or contributing factors are unknown. And you find a lot of examples in the companion document explaining how to differentiate these scenarios. In addition, there is a PT therapy interruption, and it's important to understand when to use this PT. This PT really has to be distinguished from dose omissions because it refers to scenarios where a therapy interruption takes place because of non-clinical factors or external factors such supply, drug supply, insurance, or financial issues. In our example, the patient made a conscious decision to omit several doses of her medication because of medical reasons. She intentionally omitted a few doses of her immunosuppressant because of exposure to COVID-19. And this represents an intentional drug misuse. And because several doses were omitted, LLT intentional misuse in dosing frequency is the most specific LLT we can select. Here we are. We would code First of all, the root cause, exposure to SARS-CoV-2. We would capture the actual deviation from the treatment regimen, the intentional misuse in dosing frequency under PT intentional product misuse. And we would, of course, also capture the subsequent adverse event in the patient, the aggravation of her underlying disease, that is the rheumatoid arthritis flare-up under PT rheumatoid arthritis. Any questions, Jane?
Yes, there's comments, Carol-Ann. Comments, we've got some about the other previous example, the insulin. So I think if you leave a couple of minutes at the end of the session, we'll come back to that one. This one, okay. There's a comment from our attendees that, are you overinterpreting by saying she skipped the doses because she was afraid her immune system might not cope? This is what you suggested was going on behind the scenes. And is that actually an overinterpretation by assuming that it's intentional?
Yes, that's always, it's always the problem of keeping the balance between reasonable medical considerations and over-interpretation of what has been reported. Here we are told that the patient skipped a few doses, so she made a conscious decision of her immunosuppressant. We know what kind of drug it was, after exposure to a COVID-19 positive relative. So it's put in context here in the verbatim itself. And I think it's reasonable to make the assumption here that this was a conscious decision of her part. It was a misuse because it was for therapeutic reasons and because of an exposure to COVID-19. I think it's a reasonable medical consideration. I hope you can agree.
Yes. I think it's right. In real life, the examples don't have everything in them, do they, that you want? So it's, as you say, it's a balance. That's all we have in comments on this one, Carol-Ann.
Thank you, Jane. So then let me continue. In our next example, a pharmacist mistakenly, used only half the intended amount of diluent when preparing the COVID-19 vaccine. Patient received the full volume of the vaccine for his first dose, as specified in the label, resulting in an overdose. He had no reactions in the follow-up exam. So what happened here? What is being described here? Before administration, the vaccine in the multi-dose vial had to be reconstituted with a defined volume of diluent, meaning that a defined amount of this diluent is mixed into a concentrated form of the vaccine to achieve the desired diluted concentration for administration. So that's the first step. And afterwards, a defined volume of the diluted vaccine has to be withdrawn from the multi-dose vial for the individual doses. That's the second step. But in our case, only half of the intended amount of diluent was used by the pharmacist for step one. And afterwards, the full defined volume of the diluted vaccine was administered to the patient. Look at the verbatim to understand what has to be captured here. We can answer the first 5 questions again. And I could not put the narrative on the slide because it was too long, but Jane has put it in the chat so we can see it here in the chat. So how would you code this one here? Dose calculation error, wrong technique in product usage process, vaccine incorrect diluent volume, vaccine preparation error, inappropriate dose of vaccine administered, accidental overdose or vaccine overdose. And would you select no adverse reaction in addition, because we were told that no reaction occurred in the patient. What would you do? This one. Obviously, split coding is necessary here. It's a chain of events. More than 100 of you have already more than 110 votes. Now let us look at the trends. Oh, we have a split of opinions. Dose calculation, wrong technique, vaccine incorrect diluent volume, vaccine preparation error. Most of you are voting for vaccine incorrect diluent volume and accidental overdose and no adverse reaction. So let me close again the poll, use our flow chart again. So did this incident happen intentionally or accidentally? It was obviously unintentional. It was caused by the pharmacist, an HCP. In the context of therapeutic use, he was preparing for administration, and meaning that the incident has to be classified as medication error again. And when looking into the browser for our terms, dose calculation error is of, here we are, go to browser. It's grouped under medication errors, product use errors, and issues. Here we are. So this is not correct. This would not be correct because this was just not a mathematical miscalculation by the pharmacist. He just didn't follow the instruction of the label and used the wrong volume of diluent for whatever reason, we don't know. Maybe he was distracted or under time pressure. But this was not reported. Wrong technique and product usage process. Let's look for technique and search. Wrong technique and product usage process. Here we are, go to browser. You see that these LLTs, we're looking into the LLT content, these are more technical issues in preparation of the product. Tablet crushed, split, inappropriate cutting, needle priming not performed, product cleaning error by user. So this doesn't seem to be suitable. Again, when I look into technique in the concept description, the manner of performance, method, operation, procedure, or details used to prepare a product. So pharmaceutical technique, aseptic technique. This is not fully suitable for our verbatim. Wrong technique in product usage process. So you see that they are all rather technical aspects. But what about preparation errors and issues? And let's do a top-down search again. Product preparation error. Product concentrate not diluted. Incorrect diluent used. Incorrect diluent volume. Here we have an exact match to what has been reported here. And if you do a right mouse click and say open history, you see it's a completely new term, also new PT that was added to the latest version of MedDRA, that is version 25.0. So this would perfectly capture what has been reported here. Vaccine preparation error was another option, but this was, of course, is much too vague. Here it is, vaccine preparation error. With a vaccine incorrect diluent volume, we would be much more specific. Inappropriate dose of vaccine administered, we said that the vaccine concentration was too high, and know that the full indicated volume of the diluted vaccine was administered to the patient. So meaning that the dose that he received was too high. This LLT would be too vague, inappropriate dose of vaccine administered. You would find it, of course, under the administration errors. Let me collapse all. Here we are. Administration errors. And incorrect dose administered. Here we have incorrect dose, inappropriate dose of vaccine administered. Here it is. So this would be too vague. We said that the vaccine concentration was too high and know that the full indicated volume of the diluted vaccine was administered to the patient. So we would need to consider an overdose, and overdose was also reported in the verbatim. No, now we have two options there: vaccine overdose and accidental overdose. And both are separate PTs. You find the overdose under HLGT overdoses and underdoses NEC. It's a general term, does not contain the information whether it was intentional or accidental. The accidental overdose can be found under product administration errors and issues. And here we have the accidental overdose. No specific term for vaccines, so we would just code to vaccine overdose. And the last option in the poll was no adverse reaction. Oops. Here we are. Go to browser. You see it's in a general SOC. No adverse event is the PT. And if you look into the LLT content, no adverse effect, no adverse event, no adverse reaction, no adverse drug effect. So if this information is useful for the safety analysis for your products, you may decide to assign comparable LLTs when it is reported that no adverse reaction or no adverse event occurred after product exposure. But it is not required by the points to consider document. It is up to you to choose this option. If you do so, document it, your rules in your in-house coding conventions, and ensure that the defined rules are applied consistently. Now let me show you again here the concept description of technique as a reminder, and the guidance from the MedDRA term selection points to consider document for the use of LLTs like no adverse effect or no adverse reaction. If it is explicitly reported that no effect, no reaction occurred after product exposure, the preferred option is to not use these LLTs, but to only code the specific medication error. And we are provided with a related example. If it is reported that a medication was given intravenously instead of intramuscularly, but the patient did not experience any adverse effects, then selection of LLT intramuscular formulation administered by other route would be sufficient. This would be the preferred option indicated in the document. But you could, of course, also take the alternative approach and code no adverse effect in addition. But again, document your rules in your coding conventions and apply them consistently. Now here we are with our final proposal. We would code to the specific LLT vaccine incorrect diluent volume, and most of you have voted for this LLT under product preparation error. We would code the accidental overdose under same PT, and you could also consider to code the no adverse reaction in addition under PT no adverse event. And of course, the COVID-19 vaccination may be captured as either an indication for use or medical procedure. Any questions?
A couple of questions here around that issue of no adverse event, and if the coder decides to capture that, do you capture it if it's only explicitly mentioned, or would you wouldn't make that assumption, would you?
No, you wouldn't make any assumption, but you would only consider to code this in addition if it's explicitly reported that no reaction, no adverse event occurred.
Okay, and how would you decide between no adverse event and no adverse reaction?
I would go with the verbatim. Here it was reported that no reaction occurred, so I would always try to stick to the wording of the verbatim.
And then could you just distinguish for us between, in this scenario, why you would choose accidental overdose and not vaccine overdose? Because surely with the accidental element, you've captured that already with your other choice of PT.
Yes, but the vaccine overdose on the PT level, you just end up with overdose. You would capture the vaccine on the LLT level, but for analysis purposes, because analysis is run on PT level mostly, you would need the information that this was an accidental overdose on PT level, and that's why the PT level has to be considered in this instance. So if you would choose LLT vaccine overdose, you would end up with PT overdose only. You could, of course, consider change request if you would like to have the information vaccine on LLT level under PT accidental overdose. You could request a new LLT, like accidental vaccine overdose, but it would still reside under PT accidental overdose. And as I said, the analysis will be run on PT level, and then one would look for the PT accidental overdose to calculate incidences.
Thank you, Caroline. That's everything for now. Hold on. Does a MedDRA accidental vaccine overdose exist? No, is the question.
No, it doesn't. It doesn't.
No. Okay, that's everything, Caroline. You carry on so you can do more examples. Thank you.
So this is one that we have received from a previous attendee of the workshop. Here it is reported that due to a supply chain anomaly, patient received his chemotherapy diluted in 1 liter of 0.9% sodium chloride bagged in a PVC containing container. And it is supposed to be diluted in 1 liter of 0.9% sodium chloride bagged in PVC free container because of known incompatibility with PVC of this chemotherapy agent. After identification of the error, the patient was monitored closely, and he experienced no adverse consequences, so no adverse effects. This is our verbatim, a long one again, and we can answer the first 6 questions here because we have a root cause for this error. So we have also to consider split coding in this instance. So which LLT or LLTs would you select for this case? It's a long narrative, that's why you can't see it. But again, Jane has put this verbatim in the chat so that you can look at it. Which LLT or LLTs would you select? I already mentioned you would need to split code here. What would you do? Supply chain anomaly would be the root cause. Then the chemotherapy was bagged in a PVC containing container, although this should not have been done because there is a known incompatibility with PVC. And then the patient was monitored after identification of the error, and we know that he experienced no adverse effects, no adverse event, incoming material container out of specification. Supply chain anomaly. No adverse event. Okay, in the interest of time, drug supply chain interruption, product preparation error, no adverse event. In the interest of time, let us continue. Inappropriate dilution, product supply issue. Well done. Yeah, it's just an anomaly that was reported. So product supply issue would capture the fact that something was wrong with the supply, but we don't know any details. So that would be a good approximation to the more vague term that we, or vague information that we received in terms of this product supply anomaly. So again, decision making, we know it was accidental. We are told it was made in error. It was made by healthcare professionals in the context of therapeutic use, again, a medication error. And you may know that PVC is used extensively for a wide range of purposes and materials, and also for the production of medical devices, such as medical tubing, blood and infusion bags, etc. And the use of plasticized PVC is useful for a number of reasons. First of all, the flexibility in a variety of physical forms. Then it's chemically stable and can be sterilized, and it has low cost and a wide availability. But unfortunately, some antibiotics, chemotherapeutics, like in our example, lipid emulsions, etc., jeopardize the chemical stability of this plasticized PVC, leading to leaching of plasticizer from the PVC containers and tubing into the IV solution. And this then can pose potential health risks to patients. So this is why it's a relevant topic. Let me switch to the browser again. So we had some suggestions with out of specification. Out of specification, we find 43 terms here, out of specification test results. So if you click on such LLTs, you will see that these are always grouped in product issues. So these can be considered product quality issues. The product quality issue was not reported here. It was just reported that due to a supply chain anomaly, wrong containers were delivered, and that the error was not detected, and these were used for chemotherapy administration for this patient. So it's not really reported that this was an out of specification test result. What has been reported is a product supply issue that was not further specified. It was just an anomaly. We don't know whether there was an interruption. This was another proposal. We don't know whether it was interruption or something else. So product supply issue would really best capture the vague information that we have. But we would at least capture the fact that there was a product supply and availability issue. Then the drug was administered, and it was administered in a wrong device. So we have to capture the stage where the error occurred, administration stage. Admin, drug, and device. Drug administered in wrong device. It is the wrong device due to the supply issue. So this would be the best LLT that we can find in the browser in order to capture both the stage and the specifics of this medication error, drug administered in wrong device. And we would, of course, also have to capture the fact that there is a known incompatibility between the drug, the chemotherapy, and this device. And if I look for it, you see drug device incompatibility. Here it is device incompatibility issues. And this is under device issues, under product issues. So it is an issue with the quality of the device. There is an interaction with the chemotherapy because it's a PVC containing container. And there's a known incompatibility between the two. And we have to capture this information, drug device incompatibility. And optional, again, you can also select LRT, no adverse effect, based on the same discussion that we had with the previous example. It's not the preferred option. It is up to you if you take either the preferred option and not code no adverse effect, or whether you decide for your organization to capture the fact that no adverse effect was reported because of safety consideration, safety analysis purposes for your products. So here we are. And that's why we would first capture the root cause, the product supply issue, same PT. We would capture the stage where the error occurred, drug administered in wrong device. And we would capture the specifics of why this was the wrong device, because of the drug device incompatibility. And depending on your approach, you would also, you could code to no adverse effect under PT, no adverse event. Any questions, Jane?
Yes, we've got one question and one comment. So the comment is about your interpretation of this as accidental. You say it's due to a supply chain anomaly. Can you just explain a bit more why you think this one is an accident, why you're treating it as an error?
Yeah, so first of all, it's really stated in the verbatim, after identification of the error. So there was a supply chain anomaly, and it's clear that the wrong devices, the wrong containers were delivered to the clinic. And this was not detected. It was an error. And then, although there was a known drug device incompatibility, these PVC containing containers were used for administration of the chemotherapy. That's why it can be considered an error.
Thank you. And then we've got a couple of alternate terms being suggested. So Aline, first of all, says, what about medicinal product interaction with primary packaging?
Yeah, that would be medicinal product. It's more vague. The drug device incompatibility would be more specific. You would always try to code as specifically as possible. Here you have a clearly, it's a known incompatibility with PVC of this chemotherapy agent. So that's why drug device incompatibility would be more specific in this instance.
And then what about product container type incorrect? Issue suggests product container.
Yeah, it is again, it's more vague. It's an incorrect container, fully clear. But why is it the incorrect container? Because of this known drug device incompatibility. This LRT already captures the fact that a wrong device was used for drug administration.
Thank you. That's all we have so far, Caroline.
Okay, then I will try to capture one more because it's more easy. Patient accidentally withdraw the immunoglobulin from 3 of her 4-gram vials to get to her 9-gram dose instead of 2 of her 4-gram vials and 1 of her 1-gram vial. And you have to know that immunoglobulins are really expensive medications. So she wasted a lot of her expensive medication by doing so. And this is something that was really received by a previous attendee. So he suggested this verbatim for discussion at our workshop here. So again, we will have to look at our verbatim. We can answer the first 5 questions. No root cause was provided. And here are your choices. Patient accidentally withdraw the immunoglobulin from 3 of her 4-gram vials to get her 9-gram dose instead of 2 of her 4-gram vials and 1 of her 1-gram vial. Dose calculation error, wrong technique in product usage process, drug dilution in inappropriate volume of solution, wrong concentration prepared, intercepted wrong dosage form selected. What would you do with this one? It's tricky. And there's no ideal hit, I have to say, but there's one LLT that really is suitable as best approximation to what has been reported here. Let me show you. Most of you are voting for wrong technique and product usage process, but many of you also are voting for dose calculation error or intercepted wrong dosage form selected, or drug dilution in an inappropriate volume. Let me close this. Use our flow chart. We know it was accidental. By whom? By the patient. Therapeutic intention, yes. It was a medication error. So she deviated from the instructions and she wasted her medication. Now let me search again in the browser. Dose calculation error. So again, this was not a mathematical miscalculation by the patient. She just didn't follow the instructions and used the wrong vials for the preparation of her next dose, wasting quite an amount of the expensive medication. So it's not a calculation error. Wrong technique and product usage process. Oops. Here we are. Go to browser. Here we are again with the technique terms. So there is no specific terms here that would, we already talked about this technique and we looked at the concept description. So there's no specific LLT and this PT that relates to they relate all to technical aspects, but we do not have a very specific one that would indicate wasting of medication. Wasting, there's no wasting. This would be, wasting is something here, cachexia, fat wasting. This has nothing to do with medication. So this would be out of scope of MedDRA actually, wasting of medication. So a wrong technique, the wrong technique in product usage or drug usage process in this instance seems to be a good approximation to what has been reported. It's a technical aspect there. She is just using the wrong vial in order to prepare her medication for administration, but she is not miscalculating the dose. She is not using an inappropriate volume for dilution because she doesn't have to dilute anything. She just mixes the vials in order to get her 9 milligram dose. Same is true for wrong concentration prepared. So no preparation error. It's just a technical aspect that she is taking the wrong vial. Instead of the 1 milligram vial, she is taking the one with the 4 gram dose. And some of you have also voted for intercepted wrong dosage form selected. And this was actually also something that the previous attendee considered for code assignment. The terms in MedDRA for medication errors are really very specific. And before selecting such a term, you should be very clear about the meaning. And dosage form, if you look into the concept description, dosage form, the physical form in which a drug is produced for administration to recipient, like if it is a tablet, a capsule, a cream, etc. So it's a physical form. Here, there is no change in the physical form. It's just a vial, it's a liquid, it's an immune globulin, but there is no wrong dosage form that was selected. It was the vials that the patient took, and but she mixed the wrong vial when preparing her drug for administration. Let me show you. So in this instance, the best approximation here is really to code wrong technique and drug usage process under wrong technique and product usage process. It's a technical aspect. She is wasting medication. She is not selecting the correct vial here. The content is okay, concentration is okay, but she's preparing the correct dose, but she's wasting 3 grams of this expensive medication. That's what happened here. Any questions, Jane?
Yes, we've had a question. Why would this be considered an ICSR if she's getting her dose, but she's taking out of the wrong things? What term would you consider to be the ADR? Is there an ADR here?
No, this really depends on reporting requirements that may differ from region to region. So it is an aspect. Many regulators require to not report these as an ICSR unless there's an adverse event in the patient or something is suspected. But they request us to collect these incidences and provide them in periodic safety reporting. And that's why they are looking at these terms or at these incidents in order to identify any maybe labeling issues like misleading instructions in the label. If there's frequent occurrences of such wrong technique and drug usage process incidents, this may indicate that something is wrong in the label, and regulators may look into the label in order to identify any misleading information that is in the label. That's just one example.
And can we go with incorrect dose administered from multi-dose vaccine vials? Incorrect dose administered from multi-dose vaccine vials is the suggestion.
So first of all, it's not a vaccine, and it's not the incorrect dose. So the dose she has finally administered is fully correct. She wanted to achieve the 9-gram dose, and she did so. But she used the wrong vial, and she wasted 3 grams of her expensive medication when preparing the drug for administration.
That's all we have, Caroline. And
okay, then
comment from earlier. We had a comment going back to the insulin, to talking more generally about storage errors. Are there any circumstances where a storage error could be intentional? Why we tend to treat the storage errors as always accidental, but maybe circumstances may be that it wasn't intentional.
Yeah, but you would always think that a storage error, so when there is a too high temperature, too low temperature whatsoever, if you have such circumstances, you always run into the risk of deterioration of the medication, so that the quality is not as it should be at the end, depending on the time frame where the storage conditions are not met. And that's why it is considered that this would not be done intentionally, because you would not, either by the patient or consumer or by the healthcare professional, but because you would never want to risk the fact that the medication deteriorates and doesn't meet the quality requirements anymore before administration.
So you'd want it to say very clearly that the patient deliberately stored it in a particular way. The example given was that maybe they were traveling or something and they knew that they were doing wrong, but they deliberately did that, stored it wrongly. And then it would have to be explicitly reported for us to treat that as misuse. Is that correct?
Yeah, but it's I doubt that this would ever be reported. But if this is an intentional decision due to medical reasons, then it would be a misuse. I don't know whether this is really a realistic scenario, to be honest.
Thank you. Thank you, Caroline. That's all the questions and comments that we've received today. Thank you.
Oops. So then let me switch to the end of the presentation. Here we have the summary of what we have done today. So 2 exercises are left. They will be shifted to the next workshop that is scheduled for end of August, if you want to join there. So we will shift them so they are not lost. And what we did today is to briefly review the general principles for coding of medication errors, and we performed coding exercises to apply these principles. Are there any last-minute questions, Jane, that we did not address so far?
No, I don't think so. Let me just scroll down to double check. No, nothing more. Thank you.
So I see that many of you are already taking the survey. Thank you for that. It's always important for us to get your feedback, what we could do better, what you liked about this workshop, and also you could provide us with some suggestions for verbatims for future workshops as well in this survey. So thank you for doing so, very helpful for us. Thank you for taking your time, but it's really short. It doesn't take a lot of time on your end. Here's some useful information regarding our website, where you can find helpful information, the email of the MSSO help desk, where you can also submit suggestions for verbatims for future workshops. We also have a FAQ section where you may find useful answers for your own questions as well. The links to our MedDRA browsers and to our training schedule, where you can register for our trainings, and to the MedDRA support documentation, where you find the ICH guidances, so the points to consider documents, both for MedDRA term selection and the companion document. And if you look on the website and click on content, you will see that we are represented in Facebook, LinkedIn, Twitter, and also on YouTube. We have social media channels, WhatsApp groups in English, Spanish, French, and Russian, and a WeChat group in Chinese. We also have a live chat where you can immediately have contact with our colleagues of the help desk, and you can also write us your questions via the contact form. Now let me show you the YouTube channel. Here we are. Contact. If you click on this icon, it will bring you directly to the YouTube channel, and here you will find all the recorded webinars sorted by the trainers. Here it's me, and if you click on the complete playlist, you see the MedDRA coding of medication errors part 1, the general principles webinar. So if you were not able to attend this webinar, it's really recommendable to watch this recorded session, because it better explains the principles for classification of medication errors and other product use issues. I did run through this very shortly today. Here you will find more explanations, more examples to better understand how to classify these medication errors and product use issues. And in a few days from now, you will also see the recorded workshop of today or the Thursday workshop, depending on audio quality. So very useful if you were not able to attend one of the sessions. You can also watch these sessions in Korean, in Spanish, in French, in Chinese. So you can really choose from a wide range of options for your training purposes. Now with this, I would like to show you the training schedule. So these are the workshops this is the one we have today. There are 45 seats left for the workshop on Thursday. So if you have colleagues who were not able to register and may be interested, you can tell them that there are still seats to be taken on Thursday. And with this, I hope that you found this new webinar helpful for your work, and hope to meet you again in one of our coming medication error workshops or other webinars that we offer. Thank you for joining today, and a big thank you also to you, Jane, for supporting me today. Enjoy the rest of your day, and a warm goodbye to all of you. Bye-bye.
Thank you, everyone. Thank you, Caroline. Bye-bye, everyone. Bye-bye.